Assalamu alaikum. Hello and welcome all, and apologies for the slight delay in the start of this webinar tonight. The date is the 5th of October 2020 and the time is 7 p.m. here in the UAE. My name is Gerard Moore from Focus Gulf Conferences and I will be your technical support manager for today. If you have any technical problems, you can message me on the admin only button located on your chat bar. If you have any serious issues, you can press the red reconnect button located at the top of your screen if you are an attendee. The webinar today will last for 1 hour and will be recorded and available for 4 days after today. We would like to thank SSMC and Saha, as always, for their endorsement, and Novartis for their continued partnership in this event. I will now hand over to our moderator, Dr. Ahmed Shatila, for the formal introductions.
Thank you, Gerard. First of all, I would like to welcome everyone to joining the webinar today. As I say every time, these webinars cannot happen without the participation of the audience and the continued support. So for that, I appreciate it and I thank you. Today I have with us Dr. Deeb. He's a neurologist who is in private practice in Dubai, and he is going to talk to us today about triggers and negative lifestyles affecting headaches and migraines. Dr. Deeb, the virtual floor is yours.
Thank you very much, Ahmed. Good evening and welcome everybody. I don't really know who everybody is, but I imagine many of you are patients with headache. So I hope that you find my upcoming talk of use. I've been asked to speak about triggers and negative lifestyles affecting headaches and migraines. My name is Dr. Deeb. I'm a neurologist in private practice in Dubai with an interest in headache. So when we say headache, what are we actually talking about? There are over 200 different varieties of headaches, and they are really outlined in the International Classification of Headache Disorders scheme. But we will concentrate our talk today on the two most common types of headache, and that is tension type headache and migraine headache. Tension type headache has a lifetime prevalence of over 90%. Migraine headaches have a lifetime prevalence of about 12%, being much more common in women, of course, than they are in men. Before we talk about the triggers and the lifestyles, I just want to make sure that we all know what we're talking about. So what is tension type headache? Tension type headache, here are the diagnostic criteria. And by the way, I'm sure you already know this, but let me say it anyway. There's no specific blood test, scan, or any other investigation that we do to make this diagnosis. If we ask a patient to do any such investigation, it's actually to exclude any other underlying cause. Once we are secure that there's no other underlying cause from the history, from the physical examination, then we have to make sure that if we say that someone has tension type headache, that they fulfill the criteria for tension type headache. So what are these criteria? Well, as you can see, you should have at least 10 episodes in your lifetime before you call it a tension type headache. Now, it may be a tension type headache the very first time it comes, but you need to have it again and again and again before we are 100% certain. Why is that important? Well, it's important more from a research perspective, because if somebody is doing research on tension type headache in China, we want to make sure that they are talking about the same thing that someone doing research in Zimbabwe is, or in Dubai, or in London, or wherever they are. So these headaches last anywhere from half an hour up to 7 days. So a headache for 2 minutes is not a tension type headache. You should have two of the following four characteristics at least: that the pain is bilateral, meaning on both sides of the head, that it's pressing or tightening, it's not pulsating or throbbing, it is mild or moderate in intensity. We usually like to use a scale from 0 to 10, where 0 is no pain and 10 is the worst pain you've ever had. So this would be more in the mild or moderate range, and not aggravated by routine physical activity such as walking or climbing stairs. You only need two of these four. In addition, you should have no nausea and no vomiting. And if you have light or sound sensitivity, photophobia or phonophobia, you may only have one of them. You cannot have both of them. And there should be no better explanation. So a feeling of tightness around the head that is 3 out of 10, that is not stopping you from doing things, with no nausea or vomiting, no light or sound sensitivity, lasting half an hour or 2 or 3, a day or 2 or more, may simply be tension type headache. It's very common. Over 90% of the population will have a tension type headache sometime during its lifetime. The second most common type of headache is migraine headache. And there are many different kinds of migraine, the most common of which is migraine without aura. How do we make that diagnosis? You should have at least 5 attacks, and the pain here lasts anywhere from 4 hours up to 72 hours. So pain that lasts for 1 or 2 hours or half an hour is not migraine. Of course, if you take a medicine and it stops, it can be. But if it stops by itself, it's not. Now, in children, you can have shorter duration, but in adults, it's 4 to 72 hours. Can it stay beyond 72 hours? Sure. And then we call it status migrainosus. It's a complication of migraine. But for the run-of-the-mill, regular migraine headache, it's from 4 hours up to 3 days. Then you need to have at least 2 of the following 4 characteristics. That it's one-sided, unilateral, that it's pulsating, that it's moderate or severe, and it's aggravation by or causing avoidance of routine physical activity. So you can compare and contrast this to what we said about tension type headache. Remember, tension type headache was bilateral location, migraine is unilateral. Tension type headache was tightness, this is pulsating. It was mild or moderate pain for tension headache, this is moderate or severe. Somebody with a tension type headache can go to the mall, can go play sports, and their headache can go away. Somebody with migraine, the least bit of movement makes them feel worse. And as you can see here, you only need 2 of 4. So the pain does not have to be unilateral, does not have to be pulsating. If you have a severe pain worsened by movement, that can be migraine. That's why the wording for migraine in Arabic, as-suda' an-nusfi, which means headache on half the head, is not really correct. It may or may not be. The proper term in Arabic is al-shaqiqa. Okay, so you've got a headache that's anywhere from 4 hours to 72 hours. You've got 2 out of those 4 things, but that's not enough. You should have at least 1 more characteristic. Not nausea with or without vomiting. But if you don't have nausea with or without vomiting, you must have both light and sound sensitivity. And again, there should be no better explanation. So these are the 2 most common types of headaches. 1 billion people on this planet suffer from migraine. It's a very common condition, frequently goes undiagnosed for many years because people say it's just a headache. Well, as you've seen from prior talks, it's not just a headache. One thing I want to say about the patient with migraine, that the patient with migraine has a brain that's extremely sensitive to change. What does that mean? Well, if you wear a blouse or a tight shirt around your neck, you will feel that tightness initially, but a few minutes down the line, you no longer feel that tightness. What has changed? Has your skin changed? Has the blouse changed? No. What has changed is your brain. Your brain was able to sense that slight tightness around your neck and adjust to it, and therefore realize it's normal and no longer be bothered by it. Patients with migraine, their brain is less able to adapt to such things. So when they go out in bright light, many of us will be able to adapt to the bright light, but the patient with migraine continues to have problems with sensitivity to that bright light, and that might bring on the migraine. And that goes not just for lights, but for sounds and smells and stress and sleep cycles and many, many other things. So the major or a main thing that I'd like you to take away is that if you suffer from migraine, your brain does not react to stimuli in the same way that the brains of other people, we'll not call them normal people, but we'll call them people without migraine, would react to it. All right, so what are some triggers? What are some things that we do to make our migraines worse? Well, here's a list of them: poor eating habits or poor eating schedules, poor sleep hygiene, ignoring or not effectively dealing with or not even recognizing emotional and psychological stressors and factors, ignoring environmental influences. What's up with caffeine? I'd like to spend a few minutes talking about caffeine as well. Dietary triggers, A lot of people spend a lot of time on this, may or may not be justified. Sedentary lifestyle, welcome to the age of corona, and hormonal factors. So let's first talk about poor eating habits. It is irregular meal times that may serve as a trigger for migraine. And that means missing meals. So I encourage patients with migraine all the time not to skip meals. No matter how busy you are, make sure that you have enough time to have that meal. Because once you skip a meal and you become a bit hypoglycemic, that can easily trigger your migraine, and that may not respond to you eating because the migraine process is already underway. And of course, eating habits includes as well adequate hydration, because dehydration can serve as a trigger for migraines. So regular meal times, not skipping meals, and adequate hydration are very important. Now, if you're one of those patients with migraines who can skip meals and not get a migraine, okay, suit yourself. So these are potential triggers for some patients. So you need to just see whether this applies to you or not. And if it does, if you avoid it, your life will be better, of course. How about sleep hygiene? What do I mean by sleep hygiene? Remember, we said that the brain of a migraineur is sensitive to change. It's not about how many hours you sleep, it's more about the regularity of it. So too much sleep, like weekends, some people work very hard during the week, they come during the weekend and they sleep extra time. What happens when they sleep too much? They can be hit with a migraine. Or if they don't sleep enough, they can be hit for a migraine, with a migraine. So it's more about the regularity of waking up and sleeping. So how can we practice good sleep hygiene? This information, for example, I took over from the sleepfoundation.org. And as a side note, I know a lot of you like to Google things. That's okay, but sometimes there's a lot of nonsense out there, let's face it. So how do you assure that you're reading something useful? Well, try to go to websites that end with .org or .edu. Usually they're academic sites, they are big organizations, and usually not for profit, and therefore you can get reliable information from these sources. So what does the Sleep Foundation of America say about sleep hygiene? Well, 4 things you can do to improve your sleep. Because if you have a sleep disturbance, your migraines will be worse. Now, if the reason of that sleep disturbance is your 3-year-old waking you up every night and not allowing you to sleep, I don't know what we're going to do about this. Get your wife or husband to help out. 1 day on, 1 day off, something like that. But if you don't have that issue, but you still have a sleep disturbance, what can we do? Well, number 1, establish a sleep schedule. Number 2, set up a nightly routine. Number 3, cultivate healthy daily habits. And number 4, optimize the bedroom. So when we establish a sleep schedule, a fixed waking and sleeping time, that helps regulate our sleep pattern. We have to make sleep a priority. Even if we have too much work, we need to realize that if we don't give the right amount of time for sleep, things will just spiral into a big mess. If we are in jet lag positions, or where we need to switch our timings, we need to do it in small adjustments. Siestas. Now, siestas are good and bad, depending how you look at them. Now, there's something called the power nap. The power nap is about 10 to 15 minutes, and it rejuvenates you, and it gives you energy for a few hours thereafter. They're very, very useful. The siesta that you see some of the South Americans practicing, it's a nap for maybe an hour and a half. Well, that also can perhaps gives you good rejuvenation. Now, you have to keep one thing in mind, that sleep cycles between light and deep sleep. If you wake up during light sleep, you'll wake up refreshed. But if you wake up, or somebody wakes you up during deep sleep, you're gonna wake up feeling groggy and heavy, and it'll take you longer to get refreshed. You will get refreshed. The effects will be seen for many, many hours afterwards, but there is that initial period of time where you will be groggy. So what is the optimal time for a siesta? People say somewhere about 20, 25 minutes, under 40 minutes for sure, because once you hit 40 minutes, you can easily go into deep sleep, and then it becomes more difficult. And then you have to sleep for a full hour and a half before you get out of deep sleep again and go into light sleep. So siestas are good for some people, but if one day you take a siesta and one day you don't, that's an irregular sleep pattern that can trigger your migraines and make them worse, actually. Set up a nightly routine. You might need 30 minutes to wind down. Okay, it's bedtime. What do I need to do? Get a routine. I put my pajamas on, I brush my teeth, I sit down, I lie down in bed, I do something relaxing for 5-10 minutes, and then I fall asleep. Dim lights, it's not really natural or healthy to go to sleep with the place all lit up. Unplug electronics. Good luck to all of us with this, right? We fall asleep with electronics in our hands. Relaxation. Some people may benefit from doing yoga or some kind of relaxation technique or some kind of meditation right before falling asleep. And use the 20-minute rule. What is the 20-minute rule? If you get into bed and 20 minutes later you're still tossing and turning, get out of bed. Get out of bed, do something relaxing for a few minutes, 10 minutes, 20 minutes, read a book, do something to calm you down, and then try to go to sleep again. Cultivate healthy daily habits. If you do the wrong things during the day, things are not going to work out during the night. So during the day, expose yourself to daylight, be physically active, avoid tobacco. Alcohol, what is the dilemma with alcohol? Well, some people can't fall asleep, so they drink alcohol at night. It helps them fall asleep, but their quality of their sleep is not so good. So it's not really advisable to use alcohol for sleep. Caffeine is an upper, it's a stimulant. If you're having difficulty sleeping, avoid caffeine from mid-afternoon onwards. Dinner time, heavy meals right before bedtime is not the best idea. And bed is for sleeping or sex. It's not to argue, it's not to plan what you're going to do with the world next. It's not to watch TV or something full of action. It is really just for those two purposes. And you need to optimize the bedroom. How do you optimize the bedroom? Well, it's the right mattress, the pillow, the sheet. If you are on rough sheets or rough mattresses and it bothers you, you're not going to sleep as easily. That doesn't mean you have to go and buy the most expensive stuff. Just find something you're comfortable with. Colder temperature in the room is more conducive to sleeping. Again, no lights, silence, make it quiet. And some people find like things like lavender, like a calming scent, may help relax them and put them to sleep. So practice good sleep hygiene, have a correct sleep schedule, because lack of sleep and interrupted sleep will definitely serve as triggers for your headaches and migraines. How about stress? Stress. Well, 20% of the population suffers from some sort of mental disorder. Stress falls under there, but you have depression and bipolar disorders. You have anxiety disorders, substance use, the most common of which is probably alcohol, obsessive compulsive disorders. You've got personality disorders and a lot of psychotic disorders as well. So all these things are present in about 1 in 5. So if you're sitting in a room with 10 people in there, know that 2 of them have at least one of these things. In patients with episodic migraine headaches, this percentage can go up to as much as 40%. And if you suffer from chronic migraine, and I didn't identify the difference between episodic and chronic migraine, but chronic migraine is when you have headaches on 15 or more days per month. Half of those days are migraine-like headaches. The other half can be any type of headaches. In people with chronic migraine, which is an extremely disabling condition, up to 60% have comorbid, which means coexistent psychological issues. It's not that one is causing the other, it's just they are there together. And if you don't control all of them, then you're not going to gain control of your migraines. This is important. If you go to a headache clinic, a multidisciplinary headache clinic in the West, when you go in there, you don't just meet the neurologist. You meet the neurologist, you meet the psychologist, you meet the psychiatrist, you meet the social worker. You fill in questionnaires beforehand, possibly a depression inventory like the Beck's depression inventory and anxiety inventories. You may even do a personality test. This is part of a comprehensive headache clinic, no matter whether you think you have a psychological issue or not. I think one thing is important is meditation. And you can do the Zen position, Or you can open the Quran and sit and read it, or go to the mosque or the church or wherever it is you like to go to do whatever relaxes you to get rid of all the stress that you're accumulating. As a sidetrack, I find a lot of my patients do not know the difference between a psychiatrist and a psychologist. If I can quickly point to the difference, a psychiatrist is a physician. He went to medical school like I did, and instead of becoming a cardiologist or a pediatrician or a neurologist, they decided to become a psychiatrist. And as a physician, they're able to prescribe medications, but they're also able to do therapy sessions. And what do they treat? Well, they treat those things listed on the slide in front of you. They treat mood disorders, anxiety disorders, substance use, obsessive compulsive, all these things. That's what a psychiatrist does. Now, most psychiatrists will go and get an extensive history at the first visit and explore all issues to understand the patient better. But then their interest mostly is in prescribing medications. If you need therapy, many of them do not do therapy, although some do, but will refer you to a psychologist who does therapy. So who is a psychologist? A psychologist never went to medical school and subsequently cannot prescribe medications, but they gone to college and they got a bachelor's degree in psychology, and they may have gone on to get a master's and a PhD and become a doctor of psychology, but they're not able to prescribe medications. So they can specialize in marital affairs, in dealing with a child from hell, whatever it is that psychologists deal with anxiety, with stress, with acute adjustment disorders, such things. So mental health is important for everybody. How about environmental influences? How can these influence your migraine headaches? And what are we talking about with environmental influences? Well, we're talking about the weather, right? If you got migraines, and you like to be in Dubai in July and August, maybe it's not such a great idea to hang around under the sun in the big humidity, right? On the beach. You may be one of those sensitive people. Maybe you need to have dark shades on. Maybe you need to have an umbrella. Maybe you need to stay in a cool place. Maybe you don't. So if you know that this kind of weather triggers your migraines, then you need to avoid it. Take off for 3 months during the summer and go to a cooler place, or just avoid the outdoors if that's what triggers your migraines. Odors and perfumes, smoke in nightclubs and bars, diesel. Many cities around the world are very polluted, and the smell of diesel can sometimes serve as a trigger for migraines. Bright lights, not just sunlight, but bright lights in a discotheque, flashing lights, okay? Discotheque, that's a word from the 70s, I guess, but it's still used somehow. Loud sounds, again, from a nightclub, there we go. These can all serve as triggers for migraines. Or at a party, some people just can't attend parties because there's too many lights and sounds and smells and smoke, and that just triggers their migraines. So noticing if there's an environmental trigger is very helpful, and if you do identify such a trigger, if you avoid it, guess what? You will have less migraines. What's up with caffeine? What's the story with caffeine? It's a bit confusing, right? You go buy Excedrin migraine. That's something in the US. It has, I believe, aspirin and Tylenol and some caffeine. You come here to Dubai and you buy Panadol migraine, which is paracetamol plus caffeine. So what's up with it? We say caffeine is bad for you, and then you give us medicines for headaches with caffeine. What's the story? Well, for some people, caffeine can serve as a trigger. But that's not very common. Actually, I thought it was rare, but I looked at a recent study from Malaysia and Singapore where the top 2 triggers were caffeine and chocolates. Chocolate has caffeine, but also has xanthines in there. So coffee can serve as a trigger, but that's not very common. What's more common is caffeine dependence and subsequently withdrawal. So take somebody who does not suffer from headaches. Have them consume caffeine on a daily basis. What's caffeine? Caffeine is coffee, tea, sodas, Pepsi, Diet Pepsi, Coke, Fanta, Miranda, but not usually the clear ones, so not 7-Up or Sprite. Energy drinks, that's where the energy comes from, right? And chocolates, not white chocolate, because that's just sugar. All these things have caffeine. If you ingest these on a daily basis in multiple portions, sooner or later you become addicted to caffeine. You'll develop caffeine dependence. Okay, it's great. It's better than being dependent on other things. The problem happens when you're doing this all week at work, and then it's weekend and you go home and you don't have your morning cup of coffee, for example, and you go into caffeine withdrawal. What are the signs of caffeine withdrawal? Well, less energy, you feel blah a little bit, and you can get a withdrawal headache. So what do? You have that cup of coffee or tea or whatever it is, and suddenly your headache goes away. So if you don't have that cup of coffee or whatever it is, caffeine withdrawal is an easy, caffeine dependence is an easy thing to get over in a couple of days, and you're back fine to normal. But what if you're a person who suffers from headaches already? If you suffer from headaches and you throw on top of that caffeine dependence, anytime you don't get your dose of caffeine, you get these withdrawal headaches, and these go on to trigger on your more severe tension and migraine headaches, and it becomes a vicious circle. So what do? You take something with caffeine and you say, Panadol Extra, help me. Well, it's not the Panadol that's helped you, it's the extra that helped you. The extra is caffeine, knowing that Panadol Extra is simply paracetamol plus caffeine. So why then do they put caffeine in these medications? Well, if you're not addicted or dependent on caffeine, and you have occasional headaches, taking a combination analgesic with caffeine in it a couple of times a month is not a bad thing. Caffeine is an adjuvant. It helps with the pain relief. So it is useful, but you have to make sure to avoid dependence, and you have to know how to use it and use it wisely. So what's acceptable caffeine? Some people say 0 caffeine. Most people say 1 to 2 units of caffeine a day. So you have to watch yourself and see, is caffeine a trigger for you? Is caffeine dependence a problem for you? If it's not, you can swim in caffeine. But if it is, then you got to do the right thing. Otherwise, you're going to get into a vicious circle, and it's going to be a problem. Okay, dietary triggers. We'll spend a few minutes talking about diet. The first thing I'd like to say is that there's no such thing as a migraine diet. And we'll talk more about this later. But there may be a food trigger. Now, you can look for food triggers, but please don't go crazy looking for food triggers. In this study from Singapore and Malaysia that I just quoted, up to 37% of patients identify the food trigger. Usually, other data I've seen, it's about 1 in 5 or 1 in 4. So 20 to 25% of patients may have a food trigger. So look for that food trigger, but if you don't find one, it's okay, you may not have one. So I'm going to tell you about some of the more common food triggers. They may or may not apply to you. Number 1 on the list is alcohol. Yes, for some, alcohol is a food. And it may be any kind of alcohol. It may be just the darker spirits. It may be alcohol from one country, but not the other. It's very individualistic. Aged cheese. Aged cheese contains tyramines, and this is things like French aged cheese, cheddar cheese, Parmesan cheese, feta cheese. All these things may serve as a trigger. Our Arabic cheeses, halloumi, Bulgarian is now an Arabic cheese. So halloumi cheese and those kinds of cheese usually are not triggers for migraine. Processed meats. Processed meats have nitrates in them, preservatives, and these can sometimes serve as triggers. So we're talking about hot dogs, salami, sausage, those types of meats that may trigger migraines. So when you talk about nitrates, which are preservatives, you can also have other preservatives like monosodium glutamate, like artificial sweeteners. Artificial sweeteners, aspartame, for example, may for some people serve as a trigger. MSG, monosodium glutamate, is a taste enhancer that you can find on lots of Asian food. It's really tasty, but it is a very well-known potent trigger for migraine. Many Chinese restaurants, many Chinese chains will advertise that they have no MSG added to their food. For some people, it is citrus, like orange juice or lemonade, maybe bananas. For others, it may be onions or garlic. It may be certain spices, mixed nuts, peanuts, chocolates that has dancings in them, and pickled or fermented foods, yogurt included, may all serve as migraine dietary triggers. But you can have no migraine dietary trigger, and you can still have lots of migraines. And these are not allergies. So lots of people waste a lot of money looking at food allergies. Now, you can go ahead and test for food allergies. If you find some allergies, maybe avoiding this food will be good for your bowel movements. It'll be good for your general health, for your energy levels also, but not specifically for your migraines. However, if your overall health is better, that will also reflect positively on your migraines. But testing for food allergies is not standard for migraine patients. So, is there such a thing as a migraine diet? There is no agreed upon migraine diet. None of the national headache societies, whether in North America or Europe, as far as I know, recommend a certain diet. Now you'll see a lot out there about different diets, that the Mediterranean diet may be very good and a low carb diet may be very good. All I tell my patients is a healthy diet is usually the way to go. And you know what a healthy diet means? It's a low carb diet and a Mediterranean diet. And there's this issue with gluten. Now, not too many people have celiac disease, but some people may have a gluten sensitivity rather than a gluten allergy. If you're suffering from severe intractable headaches, daily headaches, near daily headaches, and no medication seems to help, it may be worthwhile to try a gluten-free diet. When you say try, you really have to stick to a gluten-free diet for a minimum of about 3 months to judge whether it makes a difference or not. I'm not recommending this for people who have intermittent episodic migraines. I'm talking about extremely intractable patients. And I had a patient like this in one of my clinics today. And you don't lose anything, except actually it's very stressful to follow these diets because it's not easy to go on a gluten-free diet. But if medications don't seem to work, if we seem that we can't find the answer, then it's not wrong to try it. What is an elimination diet? Some people talk about elimination diets. Again, for people with severe intractable migraines, and most societies do not adhere, headache societies do not adhere to elimination diets because they're very cumbersome and the data is not so strong. But again, if you have severe intractable headaches, what to do? Well, one thing you can do is go on an elimination diet. What does that mean? It means cut out from your diet any and everything that has ever been reported anywhere to serve as a migraine trigger. And if your headaches improve a few months down the line, then you know that something in the diet was doing that. So you can slowly add things back on there and find out what it is that is causing your migraines or triggering your migraines. Okay, where do we go next? Sedentary lifestyle. I don't need to tell you, and you don't need to tell me. Sedentary lifestyle is bad. It's bad for your heart. It's bad for your circulation. It's bad for your mood. It's bad for your looks and your weight, but it's also bad for your migraines. A Swiss study a couple of years ago, maybe now 3 or 4 years ago, took 2 groups of people with migraine. And for one group, they just told them to walk around the block or walk around the park or do things a few times a week. For the other group, they said 25 or 30 minutes of aerobic exercise where you get your heart really pumping 3 times a week. And they followed these 2 groups of patients and they looked at their headaches. And both groups improved. However, the group that did the aerobic exercise where their heart was really pumping benefited more with a bigger reduction in the frequency and the severity of their headaches. And therefore, for all it's good, we encourage exercise. It should make things better, not worse. Now, there are those unfortunate groups of patients for whom exercise triggers their headaches. Well, that's a catch-22 there. There are medications that can be tried. Preventives may need to be used, but for most people, that is not the issue. For most people, it is being lazy and sitting at home watching TV on the couch. That's the issue. All right. The last thing I'd like to talk about as far as triggers, and then we'll have time for questions and answers, and hopefully there will be lots of them, is hormonal factors and medications. We know that for many people with migraine, with many women with migraine, their migraine may be related to their menstrual cycle, either exclusively occurring around menses or being much worse during menses and sometimes in mid-cycle at ovulation. And if we can identify such a thing, sometimes certain medication interventions can help. The oral contraceptive pill does not have a consistent relationship with migraine. For some women, it actually worsens the migraine. For some women, there's an improvement, and yet for others, there does not seem to be any effect. When I do get female patients with migraines on the oral contraceptive pill, whether it's for contraception or for skin purposes or for regulating the cycle or whatever, and their headaches are out of control, this is one option that they can have. But I tell them, I really don't know what's going to happen. You do have the option. Now, if you get pregnant off of it, you may have a bigger headache, but that's the patient's choice, I think. And we have to remember that our patients also suffer from other medical conditions and are on other medications. And many medications can trigger or worsen headaches or cause new headache syndromes in and of themselves. Many of the blood pressure medications can result in headaches. Nitrates used for cardiac disease can trigger headaches. Nitroglycerin and Roaccutane for skin can sometimes cause increased pressure behind the eyes and result in headaches as well. So there are hormonal factors and medications that can trigger and worsen headaches. I think that's all I wanted to say today about migraine and headaches in general and what can trigger them and worsen them. And I'm happy to take any questions that you have.
Thank you very much, Dr. Deeb, for the excellent lecture. Very informative, very educational, and I'm sure there are a lot of questions. But let me ask you this. So when you see a person in clinic with headaches, and as you said, it all starts with the history, getting the type of headaches, the frequency, if there's any triggers. After you've gone through the history and examined the person, what's a realistic expectation? Like when they come back a month from now and they say, I still have headaches. What do you usually tell your patients? What's a realistic goal in regards to timeline and for treatments and improvement, if you're going to see it?
Okay, so I think we have to sit with our patients and reach realistic goals. We have to talk about optimizing lifestyle and identifying triggers, if any. We have to talk about what are the acute medications that need to be used and make sure that the right medications are being used at the right dosage in the right way. And we have to talk about preventive treatments and whether they are necessary. And we have to have an idea about the headaches, and this is best established by maintaining a headache diary, which I've seen you've talked about in your previous series. That is an integral part. I think the first visit is to understand the migraines, to set up a treatment plan. And there are some patients who come to me who are having 2 migraines a month, and there are some patients coming to me who are having daily headaches 28 days a month. So the expectation for every patient is different. Some patients come to me having never tried anything for headaches before, having never heard of triptans, which is the main acute therapy for migraine. And I have other people who have tried a dozen preventives and all the acute medications there are, and they're still having headaches. So I think the expectation for every patient is different, but you need to make the patient understand what the expectation is when they come back for their next visit in 4, 6, 8, or 12 weeks, whatever it is.
Thank you very much. We'll now open up the floor for any questions. Is there still an echo or did it go away?
Yes, there's a small echo on your laptop, Dr. Ahmed. It's not fine. Thank you very much, Dr. Deeb, for an excellent presentation. We've been monitoring the questions and the chat bar and the private messages. So within the next 18 minutes that we have, we will try and get through as many as we can. So I will start with some here in the chat room. Does headaches make high blood pressure or high blood pressure cause headaches?
Okay, so pain in general, whatever pain it is, whether it's headache or bodily pain, is a stressful experience, and stress can increase your blood pressure. At the same time, elevated blood pressure can result in headache. So both ways can occur. But please remember that hypertension or elevated blood pressure is also known as the silent killer. You can have high blood pressure for many years, causing you to be at increased risk for stroke and heart attack and sudden death without having any symptoms. So please do not wait for the headache to decide whether you have blood pressure or not. You need to measure it. That's the only way of truly knowing.
Thank you very much.
And if I can add one more thing about this, please. When the elevated blood pressure is due to the pain, it's usually the systolic blood pressure, the higher number. The lower number, which is the diastolic blood pressure, is less affected by that. And if that number is high, then there's a much bigger chance that your problem is high blood pressure rather than pain causing elevation of blood pressure.
Thank you very much, Doctor. Next question is, I find that fast food causes headaches. Is this common?
Yeah, I don't know of studies specifically addressing fast food. I think everything in moderation is okay. Fast food has its own problems from a health perspective. If you're going to have a fast food meal every now and then, I don't think it's an issue. But A lot of the fast foods also have preservatives and different things in it. If you find that that triggers your migraines, then you gotta avoid it. But there's nothing specific about fast food to say that everybody with migraines needs to avoid that.
But at the same time, avoiding fast food or at least minimizing the amount can actually help your health as well. So it's, we try to tell our patients, try to eat as least amount of fast food as possible.
Yeah, I fully agree, Dr. Ahmed. Yes, as least as possible, but you don't have to avoid it like the plague. So once a month, twice a month, if you feel like having something fast food, you gotta enjoy life a little as well.
That's true.
I take regular medication from the pharmacy, but it makes me feel worse. Why?
The wrong medicine?
I take I take a regular medication from the pharmacy, but it makes me feel worse. I believe they may be referring to over-the-counter medicine. Makes me feel worse.
Yeah,
Why?
maybe you're using the wrong kind of medicine. Maybe you're using the wrong dose of medicine. Maybe you're using it at the wrong time. So that's really a very open-ended question. What you need to do is to see a neurologist who has an interest in headache. And actually, you know what? It doesn't have to be a neurologist. GPs and internists can treat headaches as long as they're knowledgeable about the headaches and they have an interest in it. So see somebody interested in headache, a healthcare professional, a physician who's interested in headache, and tell them what you're taking and go through it. That's the best way to find out, because I know a lot of people go to the pharmacy, can't be bothered, go to the doctor, but if you're not responding, then it is the time to go and see a doctor to decide maybe what you're doing is not the best thing.
Can constipation cause migraines?
Yeah, I don't know if it can cause migraines, but I've had several patients who suffer from migraines who note that when they become constipated, their headaches become worse. There is some sort of connection between the gut and the brain, for sure. We know this for multiple sclerosis, we know this for Parkinson's disease, and it is not strange that it would also be there for migraine. Exactly what the relationship is, it's difficult to identify. So if you have identified constipation as a trigger for your migraines, then you need to aggressively treat that constipation with the help of your gastroenterologist.
Thank you. The pregnancy is affecting my migraines. What can I do?
For many women, when they become pregnant, their migraines may go away or may become less severe. But that's not for all women with migraine who become pregnant. Some women get their first migraine when they're pregnant. For some women, their migraines worsen during pregnancy. What can you do? Well, women usually like to avoid medications during pregnancy. But you don't have to. There are some medications that are okay to take during pregnancy. But remember all the other non-pharmaceutical things you can do. Acupuncture, relaxation, yoga, regular eating and sleeping habits. So you need to do all the lifestyle things and optimize them. Massage and things like that. And good hydration. If that's not enough, there are medications that you can take during pregnancy, and it depends on which trimester you're in. And for example, ibuprofen, the most common non-steroidal drug, is not allowed during the first trimester, is not allowed during the third trimester, but I have no problem prescribing it to my pregnant patients during the second trimester. Triptans, like sumatriptan, the package insert says not allowed to use during pregnancy. Now, sumatriptan came out when I was still in training in the early 1990s, but now we have close to 30 years experience, and we know from Scandinavian registries that sumatriptan is safe during pregnancy, although the package insert says you cannot use it during pregnancy. So there are options there. You need to go see your neurologist, and I have to say this, not any neurologist. It's got to be a neurologist interested with headache. Not all neurologists are interested in headaches. So see somebody interested in headaches, and even during pregnancy, you can take some medications. Now, having said that these things are safe, I know some women still refuse to take medications. I just want you to realize that the stress of pain may be doing as much harm to the baby as the potential harm from any medication you may take during pregnancy. So you just need to go discuss your case with someone who knows what medicines to take, what medicines to avoid. There are some medicines which is not black and white, and you can discuss with your doctor if you accept to take them or not. And sorry, one more thing. Just make sure if you have a history of migraines and now they're getting worse, there are certain headaches that come up during pregnancy that may mean something more serious. And seeing your doctor can help you decide and make sure that nothing else serious is going on.
Thank you very much. The next question, I believe maybe a comment. Migraine has multiple trigger mechanisms, so no one can treat good. It's usually hereditary. Do you have anything to feedback on that comment?
So we don't know the exact cause of migraine. Billions of dollars are spent on research to know the exact cause of migraine. We don't know the exact cause of many diseases, and migraine is just one of them. But migraine is a brain disorder. There are signals that are starting in the brain, and there are many mechanisms that have been proposed, and I don't think this is the forum to go through these mechanisms. They're all theories in any case. But it's a brain disorder that starts with electrical impulses somewhere in the brain and affects the vasculature around the covering of the brain, the meninges, and results in the whole migraine experience. In 70% of the cases, there's a family history. So you will find a brother, a father, an uncle, a grandparent, a son, a daughter who may have it. But in 30% of patients with migraine, there is no family history.
Thank you. I will move to some private questions now that were sent to me on the private chat. This person suffers from the bright lights in their office environment. It causes them headache and it affects their work, but they are unable, or the boss does not understand. What can they say to their boss to help them understand better?
So this person is describing photosensitivity or photophobia. Okay, so sometimes that can be due to an ocular disorder. So it's good to go and see an eye doctor, an ophthalmologist, and get a full assessment to make sure that nothing else is going on. Now, photophobia or photosensitivity can also be a part of migraine. And for some people with migraine, they even have this photosensitivity or photophobia in between migraine attacks. So it's called inter-ictal, inter-attack photosensitivity. And we really don't have great medicines for this. We try to control the migraine. The more you control the migraine, we hope that this will also control any photophobia or phonophobia, light or sound sensitivity. And as we said, the brain of a migraineur is sensitive to change, and this photophobia is part of it. You may need to go see a doctor and get a letter from your doctor. You may need to use a certain, what do you call these things, that you put on the screens to reduce the glare from the screen. Yeah, you may need to use certain shades or something like this. But yes, photophobia and sensitivity to lights is part of, is a problem for some people with or without migraine. So I think seeing your eye doctor and getting a letter from them, if you have migraine, seeing your neurologist, get a letter from them, and having an employer who cares or who is forced to care would also be useful. But our letters will definitely help. If that's what's happening to you, we can try and help with that, sure.
And I've done common. They give letters, you know, specifying the triggers and then asking the employer to take these triggers into consideration. You guys still hear my echo or no?
I don't hear an echo. It's okay.
Okay, sweet. So there's been a couple of questions sent to me in private about the new monthly injection. First of all, is if it's available in the UAE, and are there any side effects? Now, what I can say that the injections are available in the UAE. There are some side effects, but I think those are better to be discussed with your neurologist. And as Dr. Deeb had mentioned, the most important thing is to find a neurologist, find a physician that you're comfortable with, you're comfortable following, and then if this is a treatment option, he or she will discuss that with you. Dr. Deeb, anything you'd like to add to it?
Yes, I think in the early 90s, the triptans for acute treatment of migraine, like sumatriptan, zolmitriptan, rizatriptan, elatriptan, naratriptan, revolutionized the care for acute migraine. And by the way, by the end of this year or early next year, we're going to have 2 new classes of medications for acute treatment of migraines for those 30–40% of patients who get inadequate response to triptans or to non-steroidal drugs. For preventive treatments, the advent of these new medications, the first of which was released in the US in May 2018, so over 2 years now, and the second of which 2 more were released in September 2018, has revolutionized the care of preventive treatment for migraines. They are available. There are great medications. They don't work for everybody, but when they do work, it's a big difference, and you will get to enjoy life again. So please go see your doctor. Go see your doctor and see if these are the right medications for you or not.
Thank you. I agree. You know, sometimes these migraines can be debilitating to a person's life. And if someone's getting routine, frequent migraines, just living a normal life, headache-free, can truly change how they appreciate life. So there are treatments available, and I think it goes back, follow with your physician or find a neurologist who has an interest in migraines.
Thank you, Doctor. Can you continue with some more private questions? You mentioned sleep is important. I struggle to get to sleep. What are the best ways to help me fall asleep?
So I mentioned some of the things from the sleepfoundation.org, some recommendations. What I would suggest is that you go to Google and put in sleep hygiene and Google sleep hygiene. You'll see that Mayo Clinic has advice. You'll see that the sleep societies have advice. You'll see that big institutions have advice, and follow this advice. Now, for some people, this really makes a big difference. For some people, despite doing everything in there, they still have problems falling asleep. And we need to know that sometimes sleep disturbance in otherwise young and healthy people, the number 1 cause for sleep disturbance is stress, and more stress, yeah, and anxiety and depression. So taking sleeping pills is not going to take away your stress or your anxiety or your depression. Right? So first you got to do the sleep hygiene things, and you can Google that by yourself. If that's not an issue, you need to be honest with yourself and see, do you suffer from anxiety or depression? And if you do, then you need to see a psychiatrist or a psychologist. Now, sometimes there are people who have insomnia without having anxiety or depression or stress, and they are doing sleep hygiene. No, there are some people who suffer from sleep problems. In this case, you need to see a sleep specialist, and sleep specialists can be neurologists or can be pulmonologists sometimes, yeah. And they can help you sometimes with medications.
Thank you. Is there any evidence or data linking migraines to the gut microbiome?
I'm not familiar with that data. There's a lot of research about it. I'm a clinical neurologist, and therefore I wait for the evidence to be there, and I try to institute that evidence to improve reduce the pain, suffering, and improve the quality of life for the patients. So I know there are many publications out there. I know there's lots of studies. What the conclusions are, I'm not really familiar with that. Dr. Ahmed, do you know more about this by any chance?
Thank you. In regards to migraines, I am not aware of any, but we know in MS there's been a lot of studies, a lot of literature pointing about the gut microbiome and whether it may cause or even trigger MS in certain people. But we're still learning more and more about that.
It is. I think it's a very interesting area. I think there's something to it, but we just haven't put our finger on it yet. And it's kind of difficult to research the gut microbiome. But I think there are many technological advances that are allowing us to do that. But I don't think we have solid answers yet. So that's why all I can say to my patients is, optimize your bowel habits and use the gastroenterologist to help you with. And you can start by not eating all the junk food you eat.
100%.
Thank you very much. We have 2 minutes left, so we'll just try and get through a couple more in that time. One question, a private question here. My headaches are always on the same location, right side of my head. It's been intense for the last 18 months, gradually getting worse. In addition, I have scalp tenderness in the same area. Is this common?
So when you have side-locked headaches, yeah, and they're not going away and they're worsening, this might be an indication for neuroimaging, like an MRI of the brain, to make sure we're not missing any underlying lesion. So maybe this person has already had neuroimaging, and if it's normal, then we can all rest assured that there's no serious underlying cause. Yet the pain remains, and you need to know that chronic pain can result in sensitivity of the skin in that area, something we call allodynia. Allodynia is a medical term which means the perception of pain from non-painful stimuli. So you take your fingers and you rub them on your scalp or against your hair, and it feels normal. For people who have allodynia, when they do that, touching their hair hurts, touching their scalp hurts. So that happens because of chronic pain. Chronic pain makes changes in the brain, central sensitization. And when that happens, you can perceive pain where there should be no pain. So is it common? Yes, we see it all the time. So first, make sure that there's no serious underlying cause by checking with your doctor about that. And second, you need to have better control of the pain. Once you have better control of the pain, if there's no serious underlying cause, the allodynia will also improve.
Thank you.
Thank you, Dr. Deeb. I have a question from one of the audience. Menstrual-associated migraines. Any treatment?
Yeah, well, sometimes hormonal treatments help. You know, I've had many patients where you can take birth control pills or take hormonal treatments and delay your periods, and all of a sudden you're not getting those headaches, but eventually you still have to have a period. Sometimes there are certain medications used around menses. For example, long-acting triptans like frovatriptan and naratriptan, Naramig and the Frova. They can be used if your cycle is regular and the pain is always happening at the same time. You can take these long-acting triptans on a daily basis for the 3-4 days around your period to try and prevent the migraine from happening. And we treat menstrually related migraines like any other migraines because they can respond to all the other migraine medications as well. So there are several interventions that can be done in order to gain control.
Thank you very much.
Thank you, Dr. Deeb. On the note of that, on October 19th, we will be having a women's health and migraine session. So any questions related to women's health and migraine, we can go in depth on October 19th. I would like to just bring your attention to next week. We will be having a webinar on managing your mental health with Dr. Samir Makul, and he will be discussing managing mental health whilst under migraines, and that will be October 12th at the same time. So you are already pre-registered. You will receive a link for that next week. This webinar has been recorded, and if you have missed it, you can revisit it in the next 4 days in the link that you will receive after the webinar has finished tonight. I believe that brings us to the end. We have exceeded 1 hour. And I would like to thank Dr. Deeb and Dr. Ahmed for their times. I would like to hand back now to Dr. Ahmed and Dr. Deeb for their final closing comments before we end the webinar.
Dr. Deeb, anything you would like to add?
If your headaches are bothering you, go see your doctor.
Excellent. I would like to thank you very much for the very interesting and educational lecture tonight. Obviously, there's been a lot of interest, a lot of questions about migraines, and this is not one of those things that we can answer in one webinar. And if we got to your question, hopefully gave you the right answer. If not, hopefully next time we'll try to get to it. I would like to thank Dr. Deeb for the lecture once again. I would like to thank our sponsors, Novartis. I'd like to thank SSNC for hosting this event, and then Gerard from Focus Goal for organizing it. With that, I will tell everyone good night, and inshallah, we'll see you next time. Thank you.
Thank you for the invitation, and good night.
Thank you all. Bye-bye. Good night.